Welcome to Next Round with the Pacific Research Institute. I'm your host, Rowena Ichon. Tim Anaya, PRI's Director of Communications, and I chatted with PRI Senior Fellow Dr. Henry Miller, a physician, scientist, and formerly with the FDA. Dr. Miller updates us on the fight against the coronavirus. He offers us much-needed perspective on what public health officials are doing to, quote, flatten the curve, efforts to find vaccines and treatments, when we can expect to get back to business as usual, and whether we should expect more viruses like these going forward. Thanks for joining us. Welcome to PRI's Next Round podcast, Dr. Miller.
Delighted to be with you, Ro.
So let's start with the coronavirus itself. We know that the virus is more contagious than the flu, and it's also deadlier than the flu. The press and other armchair epidemiologists have been throwing a lot of numbers around on the virus. Dr. Deborah Birx, the White House coronavirus coordinator, said at a White House press conference that the U.S. could actually suffer 200,000 deaths, even, quote, if we do things together well and almost perfectly, unquote. Help us put some perspective on these numbers for our listeners.
Well, those numbers are based on models, which are dependent on the assumptions that go into them. And the models' predictions have varied a great deal, but 200,000 deaths seems about right, seems to be about the midpoint of the various models that are coming out. Now, that's a shocking number, of course, and part of the reason that this virus has been so deadly is that it's almost a perfect storm. It's very contagious. There's a long incubation period, and many people who are infected are asymptomatic entirely and never develop the characteristic cough, fever, malaise, sore throat, and shortness of breath. So even if they're asymptomatic, they can spread the virus they shed and infect people around them. And so what you see is that the spread of infection occurs gradually, but because it's an exponential growth, it appears to blossom all at once. And once it infects certain demographic groups in particular, people over 60, people with pre-existing serious physical illnesses, it's often deadly.
Dr. Miller, one thing that I've been wondering about throughout this whole pandemic that we've been experiencing here, was the appearance of this novel coronavirus completely unexpected and unpredictable?
No, it wasn't, Tim. And, there are academics and public health officials who watch or are supposed to watch for what we call emerging infectious diseases, that is, new infectious agents emerging. And I'll read you 3 sentences from the conclusions of a 2007 review in a scholarly journal, prominent scholarly journal. It said, quote, coronaviruses are well known to undergo genetic recombination, which may lead to new genotypes and outbreaks. The presence of a large reservoir of SARS-CoV-like viruses in horseshoe bats, together with the culture of eating exotic mammals in southern China, is a time bomb. The possibility of the reemergence of SARS, that's severe acute respiratory syndrome caused by a different coronavirus, and other novel viruses from animals or laboratories, and therefore the need for preparedness should not be ignored, end quote. And so this is 13 years ago, and we're familiar with other coronaviruses that have caused epidemics, not really pandemics, but that have been very deadly as well, and yet we were really quite ill-prepared in many ways for this new novel coronavirus.
Dr. Miller, there's a lot of hype about a vaccine, and I watch CNN. It seems like every 15 minutes there's a new company discussing that they're just around the corner and they could be just a few months away. But I think more likely what we hear from the professionals is a vaccine is probably 12 to 18 months away. You're a physician, a scientist, a molecular biologist, and you were also with the FDA. What does it take to develop a vaccine, and how quickly can the general public have access to it?
Well, I've been disturbed by that 12 to 18-month estimate, and it's revealing that the 2 stars of the presidential task force on coronavirus, Tony Fauci from NIH and Dr. Deborah Birx, have not parroted that 12 to 18-month estimate because they know better. That's off by, I would say, at least a factor of 2, is that for a vaccine that is going to be administered to vast numbers of healthy people, the ethical, the medical, and the regulatory standard for testing is very high, and it needs to be tested extensively for both safety and efficacy. And when you look at what the bar has been for recent vaccine, there was a vaccine for rotavirus, which is a gastrointestinal disease of kids, that was tested on 72,000 healthy infants. And the first human papillomavirus vaccine, Gardasil, was tested on more than 24,000 people. And the newest shingles vaccine on about 29,000 subjects. And so it's a mammoth task to organize and perform clinical trials on tens of thousands of patients. It just can't be done rapidly. One of the constraints, for example, is that you need to do it in places where the disease is occurring fairly commonly. And the reason for that is you're doing these trials in a randomized, controlled way. You give some subjects the vaccine and others a placebo. And in order to show a statistical difference in efficacy in the occurrence of infection between those two groups, you have to have sufficient numbers of infection occurring. And so it's conceivable that you begin the studies in places where infections are occurring and are likely to keep occurring, but then you bend the curve and you don't have enough infections to be statistically significant. Once you do accumulate the data from these tens of thousands of patients, first the sponsor, the company that made the vaccine, has to accumulate the data and analyze it, and then the regulators, FDA in the U.S., has to do the same. So this is a very difficult and laborious process. And you'll hear some of the pundits saying, this is an emergency. We can't wait for that kind of surety. We can't wait for the regulators to take their time with this. Well, when they were trying to develop a SARS vaccine, what they found in animal studies was that some vaccines actually potentiated the illness if the animals were then exposed to the disease itself in a challenge. And this is exactly the kind of thing that could be catastrophic if we made the vaccine available prematurely to 1 million or 10 million or 100 million people. And then when they were exposed to the coronavirus in the community, the vaccine actually had the effect of exacerbating the illness instead of preventing it. So we really need to be extremely careful, and the regulators will be, as long as the FDA Commissioner, Stephen Hahn, adheres to the usual standard of safety and efficacy, and I have every confidence that he will.
You see lots of physicians and scientists are working on different treatments and potential therapies. Why is this coronavirus so difficult to treat? And why don't the usual treatments that we use for the flu work in this scenario?
That's an easy question, Tim, because it's a very different virus. It's a different class. It's a different group. To give you an example, one of the drugs that's being touted as a possibility, or was touted as an ability for treating the novel coronavirus, is a Japanese-made drug called Avigan, which is an anti-flu drug. And it works modestly well for flu. And the way it works is it inhibits an enzyme called an RNA-dependent RNA polymerase. And that enzyme is critical for the virus to duplicate itself once it gets into cells. It happens that I was the co-discoverer of that enzyme in the flu virus when I was in graduate school. And I would love nothing better than to see Avigan work on that enzyme in coronavirus, but it doesn't. It's a different enzyme, and that particular drug just isn't active on it. But the presumptive good news is that there are dozens dozens of groups working on various drug therapies. In fact, I looked it up a couple of days ago, and there were more than 100 clinical trials of various drugs and combinations of drugs underway. One of the interesting things about vaccines that are under development is that all of them, and there are perhaps a dozen or more, use novel, very innovative technologies that have never been used before for vaccine production. Now, it's good that they're very innovative, but again, it raises the bar insofar as regulation is concerned when something is completely unproven. Interestingly, and not many people are aware of this, there are two commercially available and approved coronavirus vaccines, one for cows, one for dogs. These are both produced by Merck Animal Health. The technology used to produce these is old or so-called conventional technology. One of them is a killed virus, and the other is a weakened or attenuated virus. And I'm a little bit surprised that nobody appears to be using those technologies, the old proven technologies, to try to develop a vaccine for the new coronavirus, because that would be, I assume, relatively easy to put into the kind of production scheme that Merck is currently using for the animal vaccines. And also, it would give us some confidence about safety because we have experience with those, long time experience.
Dr. Miller, there's a lot of speculation about when the coronavirus will peak, when it will slow down, when it will end, and when we can get back to business as usual. What are your thoughts on the arc of this pandemic? What additional information do we need to make a good estimate?
Well, in a way, that gets us back to the first question that you asked about the modeling that gave us an estimate of deaths. It's somewhat hard to predict because it depends on how good compliance with the strictures are. So, as you know, in California, we're sheltering in place, limiting activities to only those that are absolutely essential. We're limited to a 5-mile radius from our homes, even for walking the dog or any kind of recreation at all. And that the compliance with those sort of strictures is very, very important. Those restrictions, though, are dictated at the local or state level. And so there are about, I think, 44 states that have fairly rigid restrictions. A few don't have any at all. Florida and Georgia are about to have them go into effect, belatedly, I would say. It's really hard to tell. But I would say ballpark, the very end of April, first half of May. If things go well, I think we'll be able to turn the curve. Now, I want to make an important point about reaching the peak, turning the curve, beginning to improve. This is not like when you have a fever, you have a night sweat and you break the fever and you wake up in the morning and you're back to normal. We're still going to be on the far side of the curve, maybe below the peak and diminishing, but we'll still be in a place where there are significant numbers of infections, significant numbers of hospitalizations, and also deaths. So we won't be out of the woods even once and have just passed the peak.
There's discussion now that the virus could come back in the fall, or the virus could mutate to a different strain. So what are the possibilities of this happening? And will social distancing and washing our hands all the time and not touching our faces and, avoiding handshakes, is that going to be a way of life for us for the foreseeable future?
Well, the short answer, Tim, is that it could be. And there are a couple of reasons for that. This is looking like possibly the kind of coronavirus that comes in a wave and then disappears. And I should point out that we have experience with infection with coronaviruses. There are 7 now that infect humans. 4 of them cause the common cold, cause perhaps 25 to 35% of common cold, and they do return year after year. One way we'll have a better handle on the likely behavior of this one is to look at antibodies that appear in the blood after infection. And these are so-called serological tests, blood tests that measure antibodies to the novel coronavirus. These tests have just begun to be shipped. And once we do systematic testing of the population, we'll have an idea of how many people were infected, many of which are going to prove to be occult or undiagnosed infection, or infections that had only very mild symptoms and appeared to be the common cold or mild flu. So if a significant portion of the population has antibodies which confer immunity to subsequent infection, we'll have a better idea of whether the virus is likely to gain hold again later this year or next year. We also need to know how long those antibodies last. So we have a lot of testing with the serology tests to do before we have definitive answers.
So the president has his health advisors on one side and his economic advisors on the other. If you had to advise the president, Dr. Miller, how would you balance the health of the American people versus the health of the economy? When do you think we can come out of our shelters?
Well, I'm a physician and a scientist, so I would side with the people on the scientific side. But I think we don't cure the economy until we get control of the public health issues and threats, and we're doing the best we can with that at this point with the strictures on movement and especially the research on therapeutic agents and vaccines. But it's not going to be soon, and it's not going to be easy, I'm afraid.
Let's discuss some of the other countries, Singapore and South Korea and Japan. These countries seem to have done a better job containing the virus. They didn't have to shut down their economies like we're doing here. Were they better prepared? Were they maybe culturally more disciplined, paying heed to government warnings? What are the differences between what they did and their experiences and what we're doing now?
Well, when you're confronted with an emergent infectious disease like this, there are two general approaches you can take. One, the more desirable one, is called containment. You prevent the epidemic from occurring in your country. And the way that you do that, and the way that Singapore, Taiwan, and Japan did it, was very aggressive monitoring, screening, testing, quarantining of people found to be infected, tracing their contacts, and also isolating for some quarantine period those contacts. And that squelched it for the most part in those countries. The difficulty was that we were very tardy in this country at getting tests out. We still don't have a sufficient number of tests, and this is months after we knew that they were going to be needed. And so we have had to go to not containment, but to mitigation. That is, trying to stop the spread as best we can, but not with testing, screening, and quarantine, simply because we didn't have it in order to do that. Also, there's more of a cultural acceptance in the countries that you mentioned of government authoritarianism, of the government dictating to people what they will and won't and can't do. So Taiwan in particular has had a big data approach to very rigid control of the population, tracking where people had traveled to, whether they're indeed respecting quarantine and staying at home, and so on. So they were in a more advantageous situation in several ways than we.
Finally, Dr. Miller, the last time we had an epidemic like this was in 1918, the Spanish flu. Is the coronavirus a black swan, once-in-a-century event, or given the mobility of people and this age of travel, Could we expect more viruses like these going forward?
Yeah, I think absolutely. And that quote that I gave you from a 2007 review article at the beginning of our chat illustrates that. It's just in the nature of viruses to mutate, and these viruses, among other kinds of viruses, are found in animal reservoirs, and then under situations like that in South China, where you have so-called live markets, live exotic animals, some of which are slaughtered, all of which are in close proximity to potential purchasers, like our farmers markets, you're going to have these new pathogens arising. So I think and hope this will serve as a wake-up call that we need to be better prepared with surveillance, better prepared with equipment, better equipped with specialists.
Special thanks to Dr. Henry Miller. If you like this episode, please tell your friends and subscribe to PRI's podcast at iTunes, Google Play, Stitcher, or TuneIn. And please do us a favor and give us 5 stars. You can also listen to our podcast on PRI's YouTube page, youtube.com/Pacific Research 1. That's the number 1. Thanks for listening. I'm Rowena Itchon. Hope you'll come back again for next round with PRI.